my session is actually the most boring one here, but it's actually the most important. And the message of this course is actually that it's not to teach you to become experts in chest ultrasounds. It's actually to understand your limitations in being a chest physician doing what is technically a skill which the radiologists have perfected for a long, long time. Now, the fact that all of you are here means that you felt that there's an importance to know how to do chest ultrasounds, and you want to take your skill further forward. You're not, like I said, you're not going to be experts at the end of this course. We're going to do all the legal requirements, theoretical things I can sign you off, but the practical things you can only understand what is needed, and you need to go back to your own hospitals and then complete the book, and then carry on practicing. Okay? Now I'm going to forego with my slides because it goes through all sorts of other things. I'm going to make this into a debate. This is a very important topic because I'm just waiting for the one disaster to happen in the country where a chest physician goes and does something, and then people are going to ask, who actually gave you this training? And he'll say, oh look, I went to this course in Middlesbrough and I was signed off. I had this mentor, he signed me off. And I said, okay, and what exactly did you sign you off? He signed me off for this. But why the hell did you stick this needle into this liver? Because I thought it was a liver. I thought it was a fluid there. And then they're going to ask questions again. Now the Royal College of Radiologists guidelines for getting level 1 competency, the practical aspects of it, was picked out the air. I've spoken to Fergus Gleeson, and they thought, okay, this is what you probably need, so they came up with this thing. And the requirements are already in your textbook and in the handouts I've given you, and it's also online. What you need is to observe 20 pleural effusions being done by somebody who's competent in doing it. You need to have done 20 normal individuals, somebody watching you doing it. You need to have done 10 pleural effusions, somebody watching you doing it, and 5 ultrasound assisted, not ultrasound guided, ultrasound assisted pleural procedures, and somebody watching you doing it. And once you've done that, and then your mentor can sign you off. And you think, oh great, I'm flying after this. But actually that's not really the case. It's your legal protection for the next mistake that's going to happen. Because if you do get this signed off and go off and did an ultrasound, and then just so happened that the spleen got a chest drain into it, and somebody takes you to a side room and says, Dr. Rex, you just stuck a chest drain into a spleen, what training have you had? So you can quote all your training and bring your logbook out and say, look, it's been signed off. And as far as the Royal College of Radiologists are concerned, I'm a level 1 practitioner. It just so happened these techniques all have got limitations. Mistakes do happen. It just so happened that my mistake happened in the first case, and then you're sort of protected a little bit. But seriously, if you don't have the piece of paper, neither your trust or your MPS or MDU will find it impossible to defend you. Sooner or later, patients are going to start realizing that the ultrasounds are being done by non-trained, non-radiologists, and it's all a matter of evolution of all these things. The moment all you guys are all pioneers, but in 5 years' time, you'll find medical students and all that doing it as part of their training. And at that point, it becomes very, very important. And the level 1 practitioner needs to always have a mentor to whom they can bounce things into. Now in America, they're having the same problems as here in getting people trained in chest ultrasounds. And what they did was they actually went about it in a much better way than what our guidelines. So our guidelines were like people sitting around a coffee table and deciding how many numbers they needed. In America, they actually did a study where they took all the residents and then got them to do chest ultrasounds under supervision, and then got them assessed and had a set level below which they couldn't be considered independent practitioners, above which they considered to be independent practitioners. And they figured out how many numbers of chest ultrasounds you needed to have done to be considered a safe independent practitioner. Do you want to take a guess at the number? Approximate number?
500.
500, right?
I think 300 was mentioned earlier.
Huh?
300 was mentioned earlier.
Yeah, 300 was mentioned earlier, but that's what the Americans require to become an independent practitioner. 300, but they said about 200 is what you need. You need to have done about 200 before you actually become considered. For a long time after I started doing ultrasounds, I've been doing this for a long, long time. And initially just cowboy work in the back room somewhere, and then
still on camera, by the way.
Well, it's fine. I mean, I don't make any bones of it. I think the important thing is to actually be honest about your limitations. I used to do this and then until I realized that what I was doing was not completely accurate, and then I got more training, and then once I did what was required of the level 1, I actually found that I still was missing things, and what I really had was a very low threshold to get a second opinion from somebody else. I'm fortunate in working with very, very good colleagues. Bapu has come up to the ward on several occasions when I needed help, dropped what he did, and I used to come to the ward and make sure that what I'm seeing is right. We had a patient I needed to put an indwelling pleural catheter for, and the patient was about to sue, gone to the MP and all that, and then we thought it's a pleural. It's been classified, it had a massive pleural effusion as part of the CT scan, but when I put the ultrasound there was no fluid, it's just solid muscle, almost solid tissue. And you can't put an indwelling pleural catheter into the thing. Vapu came up and he put the probe there, and he found the same thing as me. And we went back to the CT scan, and the CT scan report was actually wrong. It had the Hounsfield unit of the solid tissue. It looked like a fluid, but when you put the Hounsfield unit, it was actually the whole massive effusion was actually massive mesothelioma. Not a mill of fluid was inside there. But the important thing is, no matter how many you've done, you need to have a low threshold for a second opinion here. Okay. Now, how many of you have gone and had a mentor identified? How many of you got a mentor? Is your mentor a radiologist or a chest physician? Radiologist. And how many of you haven't got a mentor? Right. Is it because you found it difficult to get a mentor?
Yeah, essentially.
Did you try to get a mentor?
I haven't tried very hard yet, no.
Who's from Scotland? And Scotland as well. So, and who's from Birmingham here? Yeah, you had a mentor.
Not as yet, because I'm not a respiratory trainee yet. I'm a core medical, so.
Oh, I see. Right. Okay. Fine. But remember the survey which I said I sent all the people who've been on the course before. Only about 60% of them actually had a mentor, and that remains a major problem nationally. Because attending a course is the easy bit. Actually, finding a mentor to actually supervise you seems to be the more difficult bit at the moment, and then that's where my worry is, because people come on the course, they get an ultrasound machine, and they start practicing, and then all you need is one mistake to occur, and then people who are in power will start looking into whether the criteria for level 1 training is sufficient enough. So just be careful, don't just know your limitations and then carry on with that. Okay?
Is that essential requirement to have a mentor?
Sorry?
To have a mentor, is that essential requirement for level 1 signing off?
Yes. You need somebody to, mentor is just a word which the Royal College of Radiologists have come up with. I mean, mentor means different things to different people, but what you need is somebody who's going to be supervising you. So somebody you can bounce ideas off, and I mean it's invaluable to have somebody. Even now I keep learning lots of things. I mean, these two guys know more about ultrasounds than me, so I have to go to them all the time too. Sorry.
When you think you've met the requirements for level 1, do you apply to the Royal College of Radiologists to get a certificate or something? Or?
Ah, that's an interesting question. Actually, there's no body nationally to give you a level 1 certificate. That is something which might evolve into happening. At this point in time, you need to keep your own records, and then and then get your mentor to sign you off. Yesterday, one of the consultants from the hospital north of the river came down and sat with me in my, not yesterday, from Friday, sat with me in my pleural disease clinic, and I got him to do ultrasounds for all the patients who were there, and then I was happy with this, with what he's done. He showed me his a record, then I signed him off as a level 1. Now he actually had a radiologist who was supervising him in Hartlepool. For some reason, the radiologist said they won't sign him off apparently, so he came to me to get it signed off. But
what can you do if you're not a level 1?
What can you do if you're not level 1?
Can you do nothing?
Before I answer that, can you just expand on it so all of us understand what you're asking?
You run out of hours, sometimes
Yeah.
with a massive fusion.
Right.
They're decompensated.
Yeah.
Does that mean you wait?
Okay, that's an interesting question. Does somebody want to answer that?
I'd probably do it without an ultrasound.
Okay.
So it's safer to do it without them?
Well, you'd be more. I think you'd have more protection doing it without ultrasound. You've been provisionally trained to do, pleural procedure. It doesn't make sense, but I think we've already asked that question at our trust, and they said that if you haven't received level 1 competence, then and it's they need immediate intervention, they should just proceed, and you'll be protected.
Yeah. Well, the British Thoracic Society guidelines on pleural effusions haven't actually made chest ultrasound mandatory. The reason why they haven't made it mandatory is because they recognize that there's not many people out there with level 1 competency, and if you make it mandatory, nobody will get a chest drain, nobody will get a chest procedure. So they made it ideal, or the wording was such that it was preferred but not mandatory. But if you've got somebody who's extremely unwell and he's given the perfect answer for that, your duty of care is to actually get the patient sorted first. So you can use the ultrasound, and if you feel confident, you put the drain inside, and then in our trust we've sort of agreed that if it's a pleural effusion coming in out of ours, unless the patient is moribund, you don't touch it until the next morning. If it's pneumothorax, you don't need an ultrasound, you just need a chest x-ray. If it's a passive pleural effusion, the patient's unwell, this principle applies.
Yeah, and I think the recommendation was, not officially in the guidelines, was that usually there wouldn't be an extremis unless it's a massive effusion, and if it's a massive effusion on the septic front and pyema, and as long as you're not more than 2 spaces below the inferior border of the scapula, or in the safe triangle, it's unlikely that they'll come to harm even if you do that chest drainage. It's not a small effusion, it's usually big.
The patient has to be moribund and unwell. Yep. Sorry, Ian, you had the answer.
You've raised a number of interesting issues already. My experience, for example, just last week, being on call, I had in excess of 50 referrals during that week, a vast number of which were related to pleural collections. And it strikes me the way medicine's going now is that no other discipline now is prepared to do any pleural procedure. Diagnostic aspirations with the chest tube seem to have gone out the window. And that obviously has an impact on service in terms of who should be providing this service and when.
In the West of...
And it relates to this issue here as to weekends and out of hours. What sort of governance arrangements are there? The other issue is practically is how many machines should you have in the unit for a population serving say 250,000. Can you give me some idea on those sorts of issues?
Okay, that's a fantastic question. Can somebody get the lights? Do you mind just switching on the lights at the back?
And furthermore, should you have an ultrasound machine with you in every clinic that you do in order to clarify either cross-sectional imaging? If there's a suspicious pleural modularity, should you have your ultrasound machine there to do a sort of probative clarification of those appearances?
Thank you. That's a fantastic set of questions. I'll just summarize these questions for you. Most chest physicians around the country have noticed exactly what Ian is saying, that's our on-calls have become a pleural diseases on-call. Every single pleural effusion, by matter of course, seems to be referred to the chest physician on-call to be sorted, and we can explore that because you had an answer for that. And the other question is, how many ultrasound machines does a typical hospital catering to 250,000 population need? And the third question was, do you need to have an ultrasound machine in your own, in every chest clinic you do? Okay. I've got answers for all three, but I'm going to get the audience to answer it for you to see what they come up with.
Certainly on the first part, I'm an acute medical trainee, I'm not a chest physician, and it's in the west of Scotland, our training programme director happens to be a respiratory physician because we haven't got many acute consultants yet, and he's very keen that we all should be able to do chest ultrasound, and that it's part of acute medicine's role that people coming through the front door get turned around rapidly, that we can do pleural procedures and be trained to do it such as that. So that's why I'm learning it, because at the minute we're called upon most of the time to do the pleural taps.
Yeah, to pleural taps and stuff. Yeah. That's your experience as well?
Yeah, I think in Newcastle, there is clear guideline. The respiratory physicians are extremely particular about it. Like they say, their logic is like the pleural effusion has not developed over 24-hour period. It has been present for literally weeks and perhaps days at the minimum. And if it can wait for weeks, it can wait for overnight for the respiratory physicians to sort out. So, in fact, not only they do all the pleural fluid-based procedures, ultrasound guided, but also they strongly discourage getting the X marked and then getting it tapped or put a drain in, because they say it's not reliable, and the mark can move, and the mark can be placed in a position where the patient was sitting in a different posture. Now, once you do it, the level might move. So
it's more real time, isn't it?
Exactly. They say there is no way that.
Okay. Right. Any other answers for that particular question? I mean, well, I'll try to answer that for Ian, because we found the same thing where chest patients tend to be called for pleural effusions all the time, and there's two reasons why that's happened now. One is the fact that trainees aren't as skilled in pleural procedures as they used to be before, and the second is the fact that the NPSA guidelines came out in 2008, which basically said people can die with chest drains and whatnot. So that was translated into all pleural procedures. And therefore no pleural effusions are ever touched by non-chest trainees. We did an audit here to see what happens, how long people stay in hospital when they've been admitted electively from clinic. So for example, if you say pleural effusion, get into the ward, just go there, get a diagnostic tap and go home. That's what, when I first joined here in 2004, we took a 1-year period, and we had about roughly around 60-65 patients being admitted for a procedure which should last no more than half an hour to 45 minutes at most. And we found that on average these patients stayed for 2.5 days in hospital. And there are some people staying long and some people staying less, but 2.5 days. Can anybody wager a guess as to why you think they stayed for 2.5 days, or what should really be in, out?
Waiting for the ultrasound.
Now in 2004 ultrasound
probably by the time you find equipment, and all the staff to do it, allocating them, you know.
Yeah, I mean basically there's nobody to do it, because the people who are skilled to do it were sitting in clinic.
Yeah.
The juniors weren't, because when I was a registrar, my boss would have seen a pleural effusion in clinic and said, okay, let this guy come in, and lo and behold, a bed appeared. And then the patient came in, and then you had a list of all stuff to do, and you did your on-calls and all that, and around 1 o'clock in the morning, you went up to Joe Blogg, who's sleeping on ward 9, and wake him up, Mr. Blogg, can you wake up, please? And then next day he's off. I mean, this is I'm not joking. This is what you used to do, right or wrong. Probably wouldn't do it now, but this is what we did. But then I mean, now of course it's very important that you don't do those things. But what the system has changed completely in so many ways compared to what it was, and what used to happen. If you're looking from above, what was happening was the patient stayed put, and the doctor came to the patient. To me, the solution is actually to change the whole system upside down. You keep the doctor put and bring the patient to the doctor, which is what I've done. In the last 6 years, I've got the pleural disease clinic running, which answers Ian's third question. So anybody with a pleural effusion, whether it comes, if it's in any ward, for example, comes in, most pleural effusions don't need to be in hospital, unless they've got other reasons to be. Most of them get admitted, waiting for a procedure, and they go out smoking, making friends with everybody, and until somebody who knows how to do the procedure comes in. So once you've identified pleural effusion, get a referral, find out if it's socially safe, are they very breathless, send them home and give them an appointment to come in. And in that clinic, you can have an ultrasound probe. You can have a trained clinician with an ultrasound probe with all the equipment he needs. 9 o'clock, one patient comes in, 9:45, another patient comes in, 10:30, another patient comes in, so you get 4 or 5 patients. You can use this to train your juniors as well. Anybody wanting to get the level 1 qualifications, they just come up there and start doing all the ultrasounds, being under supervision, and you're saving hospital beds, you're saving the patient the discomfort of being in hospital, and plus you're getting a very good service, plus training all the juniors.
Can I ask if say for example, you get a patient who's got a right-sided pleural effusion, you observe somebody like you would do it quickly, that's tick, and then you do it on the right side. that's the pleural effusion, and then the left side is normal. Can that patient be counted as 3 observed, then the right side pleural effusion,
Oh, right, yeah, that's a good
and the
point,
left?
yes,
Because
okay.
then you can finish.
In fact, that's what I recommend. In fact, I was coming to that. You know, the Royal College of Radiologists guidelines actually say that you need to have observed 20 pleural effusions being done by somebody, and then done 20 normal. Thing. You don't actually need to have 20 normal people. You just take 10 people and do it on both sides. And then if you got a pleural effusion, good point. You got a pleural effusion on the right side, and the left side is normal. You keep clocking up your the normal, because the reason you got to ask yourself, why do you have to do 20 normal in observation? The reason for that is because they're trying to get your brain tuned into looking for patterns, and the pattern you're looking for is the pleural gliding sign. And then that's the sign of the visceral pleura gliding against the parietal pleura. And what you're seeing is all the interlobar fissures, which have a small amount of fluid, which produces shadow, and that's sliding up and down. So when you're going this afternoon, you're having real patients, you get yourself tuned into understanding what the pleural gliding sign is. When you see the pleural gliding sign, there's no pleural effusion. Okay, so you think somebody's got a pleural effusion, stick it there, and then the thing moves up and down. There's no effusion. And why are you doing 20 is because they want to get your... you don't need to see 20 people. You got to see... Because you just have 20 normal pleura. That's all it's needed. And when... I still remember who's the BTS president now? Ian, you should know. Who's
Forest?
no? Who's in Portsmouth? Ed White, yeah. Ed Neville, yes. I remember speaking to Ed Neville about this about 2-3 years ago. He said, "Oh, we got lots of pleural effusions down at Portsmouth. We got no problems with pleural effusions. It's a normal individuals having struggles with." He said. I said, "No, normal's actually easy. Just one afternoon, get some 10 people and do it all on both sides. I mean, that's all finished, and you get all your normals easy. Pleural effusions are the more difficult ones."
Yeah.
Okay.
Can I ask what is the minimum depth of pleural thickening which you can safely biopsy by ultrasonography?
Minimum depth.
Yes.
You can biopsy any pleural. I mean, you're talking about parietal pleural thickening, I presume.
Do you see pleural thickening?
Yeah.
And the appearances on CT are very suggestive of mesothelioma. Would you biopsy that if the pleural thickening was of a certain thickness?
Right. Okay. In the algorithm I use is that if I get a CT scan, if there's pleural thickening, I biopsy it, and then we know from if you got 0.8 centimeters thickness, you're likely to have a positive hit rate.
What's the minimum thickness you would safely biopsy?
I mean, if it's anything, if the pleural thickening isn't seen on the CT scan and the ultrasound, if it's normal, which is about 1 millimeter or 2 millimeters, I wouldn't biopsy it normally. I send it straight for VATS. If it's anything more than 0.5 centimeters, which is 5 millimeters, I would biopsy it. So and pleural thickening is not actually. It took me a long time to actually understand what was pleural thickening. So it's not very easy to pick up, and lots of people feel likewise, and as far as I can see from the results coming through from delegates who've been on the course. But it's not impossible. It's something, again, you keep practicing. That's why if you just stick with the Royal College of Radiologists guidelines, you'll be very good at looking at pleural effusions and focus on that for a long time, and then go into pleural thickening. You need a high frequency probe to be absolutely certain about pleural thickening.
Yeah, when we do CT or ultrasound guided biopsies, we find it the yield being a bit low if it is less than a centimeter. So it depends. If there is a bit,
Yield meaning you won't get any tissue at all.
you get a yield, but the sample being positive for malignancy is quite low. If we don't get good size sample.
Right.
So if it is more than a centimeter, we say it is amenable to CT or ultrasound guided biopsy sometimes. We end up sending it for VATS, but it's just individual. It's it might improve the technique.
Because you're not causing them any harm in biopsy. Because when they come, the algorithm I use is they come in, they get a biopsy. If it's positive, I put an indwelling catheter and send them home, and then after about a couple of weeks, take the drain out with absorbed fluids. If it's negative, they go for VATS. Before I started putting my own indwelling pleural catheters, the pleural disease clinic failed in its primary purpose, which was to keep people out of hospital. Because once you had the diagnosis and you had to put the drain in, you had to bring the patient in. But the indwelling pleural catheters really solved the problem. And for a while I thought they were permanent. They're not permanent. You can't take them out. It's actually quite easy to take them out.
The alternative would be to do a diagnostic and therapeutic aspiration, and if you've got medical thoracoscopy set up, you can book them in the week after, and that would hopefully clear their effusion and talc.
In our hospital, medical thoracoscopy is finding it difficult to take over because we have catheterizing surgeons doing a very good VATS service. So,
I've got 2 points from a radiological point of view. One was going back to the question about emergency. If you have a machine, and there are a few conditions, you've seen the pleural effusion, and the ones that we usually dread is the ones that's in the lateral aspect. You see a pleural effusion, and it's on the lateral aspect of the chest wall. If you have a machine, I would use it, purely because you can be easily fooled to think that the biggest depth is somewhere there. At least if you have a rough idea where the best depth is, we have a case today, and demonstrate the point. If you had a machine and you knew how to use it, at least you can know where it is, then you can go blindly. That's one. The second thing that we spoke about, putting drains in, and the first one goes into the liver or the spleen. It's probably, we try to avoid it, but even if it happens, there's no way you'd have known that you've done that on many occasions. So what is recommended, at least from our guidelines, is when you've done a biopsy, you've done what we have done, you've had 3 passes, please write, I've had 3 passes, and the third one I got it. Because if it's not written, we have enough and more cases in our medical legal society where it's just a document that you've done the first, and then they have a CT after that where you have huge subcapsular hematomas, and on the CT it doesn't hide any fact. You can see where the passes have been through. You've had 2 or 3 passes, and that was not mentioned, and then the patient goes hypertensive all the rest. So once at least you can't really, you know that you're doing it in the best interest. You've done everything the right way. You wanted to avoid the spleen, want to liver, the heart. Heart I haven't heard, but at least spleen and liver, it's easily done.
can I ask you, what do you do if you stick a thing into a heart?
I really don't know that. I think I would leave it there. I wouldn't know.
What would you do if you stuck a chest drain into a heart?
Leave it there.
Don't remove it.
Don't take it out. Just leave it there. Because if you
it just happens that you put it in and you don't get fluid and you take it out.
just clamp it and leave it there and call the cardiologist surgeon.
Yeah. So these are things that we have been strongly recommended. Even if you've put it in and you've not got, please mention the notes that you tried first time, no success, second time, no success, third time I've got it.
Just a couple of points. I think I attended a teaching day. Dr. Forrest at Newcastle, he just mentioned a couple of points. He said, despite using ultrasound, if in case you've put the needle in and you're not aspirating any fluid, then that clearly means you're not in the right place. So there's no point of just putting the drain in because you're in this place. So just common sense practice. If you're not aspirating fluid, revisit your technique and see.
The technique is absolutely clear. You know what you're doing. I'm not questioning the technique. What I'm saying is the first time you didn't get it, you just mentioned first attempt, no fluid,
Right.
second attempt, yes, or third attempt, yes. Rather than, if that is not there, what happens if something goes wrong with the patient and if they question it, we at least know that your technique was flawless.
And secondly, Dr. Forrest mentions, he says that every chest drain procedure for fluids should be a work-based assessment opportunity. So it should be used because nowadays the way the guidelines are, the NICE guidelines, it's probably very limited that everyone gets an exposure. So it should be either a procedure to be observed or done by a trainee and being sort of in terms of assessment or the person who is supervising to do it. It should be used as an opportunity. So is that something that you people practice here at James School?
Yeah, routinely. We're actually far ahead of Newcastle.
Can I ask a related question? If you come around on your ward round and you think a drain has been put inadvertently into the lung, should you leave it in and get a CT scan?
Sorry, what's your question again?
If you're on, say, coming round, morning ward round, and somebody you think has put a drain into the lung, should you leave the drain in and get a CT scan to confirm that, or do you think it's better just to remove the drain?
I mean, do you think if you put a drain inside the lung will still stay the same?
Well, I'm thinking of a situation.
You've got a pneumothorax.
For example.
No,
Yeah.
no, not necessarily.
Inside?
No. Well, I mean, yeah, you might have a hydropneumothorax, but you might have an intrapulmonary drain. And the thoracic surgeons where I work, they say the same principle. If it's intrapulmonary, leave it there. Leave it there for it to be taken out. The thoracic surgeons, being available on course, they can take him in quickly, or at least a general surgeon who's got thoracic experience to be there in case.
Which kind of drainage do you use?
Well, we use both Seldinger and surgical drains.
Right.
Yes,
But I'm thinking of, the Selding, as I feel that the technique sometimes lends itself to puncturing the lung.
In the rocket kit actually comes with a safety guard, which actually doesn't allow you to go any deeper than 5 centimeters. You shouldn't really. Of course, these things are very rare. That does happen.
I think sometimes the problem with the Seldinger technique is that in the old days, which we were used to, when you clear with the finger to make sure there's no adhesion before you go into the pleural cavity. Nowadays, sometimes it's difficult when you stick it in and there's maybe adhesions, and because you don't put your finger in, as long as everything's going quite smoothly, you can sometimes get air when you go intrapulmonary, and you keep going with the procedure, and until things are not working, it just keeps bubbling.
I must admit, I've done hundreds of chest drains. This concept of intrapulmonary chest drain confuses me. You can't stick a drain into a lung without producing a pneumothorax. You can get the drain between the two lobes. That happens. That happens often, because when you have pneumothorax, you got a pneumothorax and you put a drain inside. As it expands, you get the upper on one side and lower on one side, and the drain blocks off because you're stuck between the thing. If you put a needle into the lung, you will collapse the lung. You'll get a hydropneumothorax. You can't stick a drain into a lung and not expect a lung to. It's not the same as putting a drain in a solid organ. I would wager you would get a collapse.
But the drain will still be in the lung. You would get a collapse, but the drain will still be in the lung.
That way.
That's
fine.
what I mean, yeah.
That's fine. Yeah. Drain will still be in the lung. Yeah. Good point. Right.
I just want to ask, what are the guidelines?
So let me just get permission from everybody, because the longer we go, the less time you get with lunch. Are you all okay with that?
Yeah.
Fine.
What are the guidelines for pneumothoraces? How are we expected to use? Because it's not easy to see a pneumothorax on an ultrasound. So
how do we?
Is it again recommended, or?
Right. Now you got to understand, the ultrasound can be used for a pneumothorax, but it's only for. I don't think it applies to chest patients. It doesn't apply to patients you're going to be seeing on an acute take. Because when you have a pneumothorax and an acute take, you're going to be pretty massive. You got to know the pleural line is there, the visual pleural line is there, and the patient is very moribund. If it's more than 20%, you need something done. You don't need an ultrasound for it. An ultrasound comes on its own in diagnosing pneumothoraces when the pneumothorax quantity is so small, and the risk of not doing anything is very high. And that only applies when you got somebody on the ventilator. And when you're on a ventilator, like Michelle explained so beautifully, when you're lying down on the ventilator flat, air being light gets to the under the top part of the thing, whether you're prone or you're on your back. And when the air is here, you can't actually see the pneumothorax line sometimes. And what you only see is called the sharp diaphragm line. So the diaphragm becomes very, very well delineated because all the air tissue contrast becomes very strong there. But whereas you can't be absolutely certain, and you wouldn't be able to use that as an indication of putting a chest drain in. But there are lots of papers that have come out of Taiwan where they've actually looked at an ultrasound. And what you're looking for in ultrasound in pneumothorax is the loss of all the artifacts which you normally see. When the loss of artifacts would mean that you're passing through air. There are lots of artifacts which Jeff talked about. One of them is very important, called the reverberation artifact. Can you remember that? It's actually, if you imagine the skin is there and the pleura is there, you're sending sound waves into the chest. It hits the pleura, goes back, hits the probe, goes back, hits the pleura, does it hundreds of times. But as far as the probe is concerned, it thinks each distance is an extra distance. So it draws images deep within the lung. The air doesn't actually, the sound doesn't go into the lungs at all. It just see lines within the lung. And if air is introduced between the pleura and the skin, you lose all these reverberation artifacts. Because sound goes through air, but not as good as it does through solids. Okay.